Hello, everyone. My name is Yvonne Nartey. I'm a physician at the Cape Coast Teaching Hospital in Ghana, and I'd like to share some of the experiences we had on the HEAT project in Ghana. So Ghana has a population of 30.8 million people, and previous studies have shown that the burden of hepatitis B is between 8.3 to 12.3%. We have a prevalence from a previous systematic review in 2016 for hepatitis C of about 3%. Roughly, there are about 42,000 new hepatitis B infections and 9,200 new hepatitis C infections annually. Our objectives for the HEAT project were to conduct an up-to-date epidemiological assessment to understand the burden of disease, to conduct laboratory capacity assessment, to develop a budget-based plan to guide the scale-up of testing, and to convene a coalition of local stakeholders to be able to put this plan into action. So we undertook a cross-sectional review of existing data on viral hepatitis testing from government hospitals, national databases, and selected civil society organizations in 12 out of the 16 administrative regions in the country. We reviewed testing data between January 2016 to December 2021. We looked at the testing numbers and the seroprevalence of patients that were tested in the hospital. And then we also evaluated the cost of testing and treatment. So here is a map of the various study sites where we were able to collect data from. And as you can see, it spanned the entire country from the northern regions all the way down to southern Ghana. And the study sites were comprised of various types of hospitals, including teaching hospitals, regional hospitals, and public health reference laboratories. So for our key findings, one of the key trends we noted was an unequal burden of disease burden in the northern regions in Ghana compared with the middle and southern parts of the country. So as you can see from this map, there was higher seroprevalence for hepatitis B amongst the in-hospital population in northern regions in Ghana compared to the south. We also found similar findings for hepatitis C, where the northern regions had the highest burden of hepatitis C antibody seroprevalence compared with the southern part of the country. One notable finding as well was the fact that over the last few years, there has been an increase in testing of pregnant women for hepatitis B surface antigen, and this is to do with the fact that it is now a requirement in the maternal health record books to have tested for hepatitis B. It is also required that hepatitis C is tested for, but this is done to a lesser extent. We found that the pooled prevalence of hepatitis B surface antigen seroprevalence in pregnant women was 6.14%. When we looked at testing capacity, we noted that there were a lot of rapid diagnostic test kits available for both hepatitis B surface antigen and hepatitis C antibody testing across the country. However, there was very limited access to ELISA testing, and most of the profile tests for hepatitis B were done using RDT-based test kits. Very worrying was the fact that there is significantly less access to PCR testing for hepatitis B DNA and hepatitis C RNA. And the regions that had the highest burden, that is the northern parts of the country, had the worst access to PCR testing. And even in centers where PCR testing was available, we found that testing was being performed at reduced capacity. For hepatitis B, the DNA tests were being performed at 2% capacity, and for hepatitis C RNA testing at 0.2% capacity. One of the major barriers to testing was the cost of being able to undertake a test. We noted that if a patient's monthly wage in Ghana is around $150, treatment for hepatitis B that is the annual cost of treatment, was around $260. And it was even worse for hepatitis C, where a 12-week course of pangenotypic DAAs were almost $900, which is far out of the reach of patients. The cost of workup was also quite expensive and limited access. So the key outcomes from this project was that we were able to get national level evidence for the first time for hepatitis B and C from the in-hospital population in Ghana, from pregnant women, and then we also looked at blood donors as well. And this has been one of the first projects to do so, and obviously without the coalition, we wouldn't have been able to undertake this project. We identified significant barriers to testing and treatment, and it demonstrated that there is a real need to review and update our current national policies and guidelines on viral hepatitis in Ghana. From this project, the Ghana Health Service and the WHO Country Office were also able to provide or develop some policy briefs on test kit quality, as well as the hepatitis-related costs in Ghana. And we were able to generate some evidence to have an initial discussion with the National Health Insurance Authority of Ghana with regard to the pricing of testing and treatment for viral hepatitis. We use this data for our World Hepatitis Day 2022 campaign to create public awareness and also to engage communities. And then from this study, we were able to begin to discuss the development of a hepatitis C elimination project in Ghana, dubbed STOP-HCV. So the rationale for STOP, which stands for Screening and Treatment Opportunity Project for Hepatitis C virus in Ghana, is that we hope to have this act as a short-term plan to catalyze the action for viral hepatitis elimination in Ghana. And the project is specifically as a response to an expected donation of sofosbuvir daclazavir, which we will be obtaining to treat 50,000 Ghanaians who are infected with hepatitis C. And this project will facilitate us demonstrating a public health approach to HCV treatment in Ghana, because thus far it's been very much, large teaching hospitals where there are gastroenterologists residing who predominantly look after and manage hepatitis C patients. And obviously access to these teaching hospitals would be quite limited. This project will also facilitate strengthening our data reporting systems and build capacity in terms of health information. So the objectives are to identify and link 50,000 Ghanaian hepatitis C patients to care with donated DAA medicines from Egypt. We will strengthen data reporting and health information systems through the training of healthcare staff across the country, and then review national policies and plans for viral hepatitis elimination. The key project targets are to screen 50% of eligible individuals, to ensure that 90% of those who are identified are linked to care, and then to also ensure that 95% of patients we identify initiate treatment. So currently, we are awaiting the drugs, we are awaiting the donation, which will be received in Ghana, hopefully in the coming months, and then we'll be able to initiate our treatment and linkage to care project. So thank you very much for listening, and I'm very happy to take any questions.